asked to give a talk. Excellence in the last 30 years, probably I think you guys thought that I was the only person who was around 30 years ago who remembered all of those things, which that is the case. I was a registrar at that time. And secondly is, in the NHS, so much has happened. So I think these are my reflections, and I do apologize if I miss out anything which you think was excellent, because I could not actually capture everything that would have happened, but I'll try to actually summarize. Yeah, I think it depends what your perspective about life is. This is Charles Dickens in 1859. He wrote Tales of Two Cities. And he says the best of time is the worst of time. It's how you see life. And many people in the NHS would think that it's the worst of time. Or it's the age of wisdom or the age of foolishness. I think it's a very interesting quote, and I think it's about perspective about two different things in life. How you see it. I think as surgeons, as people who are looking forward, we should have a positive tint, but at the same time you can see that times are difficult. But I thought it was a very interesting quote to start with. What the hopes are of people going towards the future in terms of NHS. So I think when you look at the life expectancy in the last 30 years, if you see African countries have got the lowest life expectancy in the world, and whereas in Asia and also in Europe the expectancy is high. In the last 30 years, life expectancy has increased from 68 years to 74 years now. So there has been 6 to 7 years of improvement in life expectancy, which is a great achievement. This is what has happened in the last 30 years. But you also see the countries as well over there. Europe is on the right side, and Asia in the middle, different countries, and Africa is on the left side over there. So you can see this has been changes, and we are a population of 8 billion people across the world. And this is what has happened. So it has an impact on what we do in the UK as well. In the same time, when you look at the the communicable disease, the burden of communicable diseases has also decreased from about 1.2 billion people dying of communicable diseases to around now 800 million. There was a spike in respiratory diseases because of COVID. But so we are working on, and we are trying to reduce the communicable diseases, which are more so prevalent in Asia and also in Africa. But on the other side, when you look at the non-communicable diseases, like liver diseases and heart attacks and all of those, they have gone from 1.2 to 1.6 billion in the last 30 years. So you can see that we are increasing in non-communicable disease, NCDs, and we are decreasing. So overall, the burden of disease actually has increased over the last 30 years. So there are more people living with multiple long-term conditions. There are more people living with conditions which people didn't have. So in terms of workforce, so how many doctors are working in the UK? About 41% of the doctors who are working in the NHS were not born in the NHS. And you can see, and we are of that group, most of us were not born in the UK. So the numbers have increased significantly as well in the last 30 years. So when you look at the number of doctors working in the NHS, in 1995, there were about 56,000 doctors working in the NHS. Now there are 146,000 doctors working in the NHS. So it has gone 3 times in the last 30 years. And when you look at how many doctors, of the total 1.7 million people working in the NHS, so what's the constituent of doctors? If you see it's a lower left corner or lower right corner, so doctors only constitute 10% of the total workforce in the NHS. So the other groups form others. So that's the demographics of what's the ratio of doctors in the NHS. So what is the best thing that has happened? I think, despite the fact we are surgeons, the best thing that has happened in improving mortality has been vaccination, in my opinion. It started a long time ago with polio and everything. But now, in the last 30 years, it was polio actually which was started with WHO actually rolled out across the world, and now only 6 countries in the world have still got some polio, but it has been eradicated across the world. So that has been the biggest achievement. In addition to that, meningitis vaccine, which came in 2016, Ebola vaccine, which was rolled out, and in 2021, we know COVID-19. So I think vaccination has been the biggest reason the mortality has come down, and that has been the biggest achievement that we have actually, or the world has actually produced. I don't know if many of you saw Matrix. It was in the 90s, again 30 years. I'm focusing on 30 years ago, this movie. It mentioned 2 pills. So there was a red pill and there was a blue pill. It depended the kind of person you were and whether you're going to take a red pill. Because I'm talking about pills. So what are the medicines which actually have come through in the last 30 years? So I just thought red pill and blue pill was a good idea. Again, Charles Dickens, what kind of person you are. So what's the best thing that happened in medication? This is atorvastatin 40 milligram tablet. I think statins have been one of the biggest changes in the last 30 years, which have changed cardiovascular disease and mortality as well. Viagra, the blue pill. This is another fantastic, I think, medicine which has come in the last 30 years. COVID-19 is not a tablet, but still, this has been a great game changer. And GLP-1 inhibitors now. I think these are the ones which would have a profound impact going forward and have already had an impact on obesity and diabetes as well. So this is, in my opinion, the medication. Imaging, PET scanning, and multimodality scanning along with PET along with MR scan, PET with CT scans. And we know that we use it all the time. And in nuclear medicine, that is also being used for treatment as well. I think imaging has really helped surgeons in so many ways. Radiotherapy, we know that now we can have hyperfractionation, intensity modulated therapy, image-guided radiotherapy, and SABR. So there have been changes in everything around us, including radiotherapy. I think one of the biggest changes, I think, has been in oncology, use of targeted therapies. Mortality in the last 15 years in patients with cancer disease has gone down from 206 patients per 100,000 to 155. So there has been 25% reduction in mortality in patients with cancer in the UK. And that has been, the biggest drop has been when checkpoint inhibitors were introduced for lung cancer. So that has been because of targeted therapies. And that has been, and if you look at genitourinary medicines, the medicines which are in the pipeline are coming through. You can see there's a huge proportion of drugs which are already in the pipeline going through different regulatory pathways, and they'll become even bigger, that we'll have a better cancer care. And in oncology, there are 2 groups of medicine I like to mention. One is immune checkpoint inhibitors, which we are using for patients with solid cancers, and they are already having significant impact, which I said in lung cancer. And CAR-T inhibitors are another group of immunological drugs, which are mainly used for blood-borne cancers. And there are 2 distinctive groups, solid cancer, and they are having significant impact. And there are more going to come in future, I think, in this area. One thing I think I need to mention is about genetics, CRISPR-9-Cas9. So it's an enzyme which allows us to refashion, readjust genetic malformations and cure genetic diseases. If you look at in urology, in infection, there are many drugs which are going through regulatory pathways. And I think once they come online, they will have significant impact on patients with hereditary disease. So I think genetics is something to look for. We have been talking about it for a long period of time. It's not something we have seen because we haven't seen the impact because they are still going through regulatory pathways for urological diseases. I think we have to, although as a surgeon, we always have got a gripe against anesthetists because they are sometimes too slow, sometimes they don't want to work with us. But I think they have been great supporter for surgery. What we do and what we are able to do is because operative care has increased significantly. We now do operations which can go on for 10, 12 hours with 3 or 4 surgical teams working because of operative care. So I actually commend what has been happening. So I think now if you see 45% of patients who come to have anesthesia, they are over the age of 65. So we're not having younger people. 65% have multiple comorbidities, they have other diseases. 41% admission to intensive care is for patients who have undergone surgery. And 12% operation have complications. So I think we have to understand that we are where we are is because we have got a fantastic perioperative care. And this has happened, enhanced recovery in the last 30 years. These improvements have come. I think I was giving perspective, so I just come back to who we are. And I think as urologists in 1990s, probably we weren't the first one, we were the quickest one, I think. We did not start MIS, it started much before us. But once we adopted it, we actually really ran with it. And I think our thought, it's a philosophical thought that it moved away from what surgeons can do for the benefit of the patient. So how can we reduce harm and improve outcomes for the patient? That was the basic, in my opinion, philosophy of MIS. It's not how good a surgeon you are technically or otherwise. It is how we can improve patient care and how we can reduce harm of surgery. Otherwise, in old time, the bigger the professor, the bigger the operation, how much big cut you can make, Kryle's operation, Commando, Bill Roth one. They were all big professors in 1950s, 60s, but known for big operations. I think urologists ran away with the idea, no, it's not about surgeons, it's for the patient. And I think we should focus on that. And all these things, PCNL, ureteroscopy, they really flourished in TURP in 90s. When I was a registrar, there was a huge discussion whether TURP is any better than retropubic prostatectomy. Huge, hundreds and hundreds of papers which said it's no good. But now where we are going beyond that. And laparoscopy we started. And because of that, then we actually focus on energy sources. What kind of energy source? And now there could be discussion whether you want to freeze something, you want to heat something, whether you want to use laser, different kinds of lasers. But it started with thinking around that you don't have to make big cuts. And you can actually, and that is better for the patient. And other specialties are following it. So I think it's philosophical change that we brought in 30 years ago. So robotic assisted surgery, which is my pet topic, I think I had to put 2 slides in it. So basically this is 2024, end of 2024. So if you look at about 17 million people have had robotic surgery so far over the last, since it started 25 years ago. And in the last 1 year, about 2.7 million had robotic surgery across the world. So if you look at national figures, the ratio of urology is reducing, but still other specialties are increasing. But when you look at your right side, this is figures for the UK. Last year's 70,000 robotics procedures were done in the UK. About, I think, 42% were in urology still. It has dropped from 88% to 42% now. The other specialties are gradually going up. And we are doing more. And there are approximately 200 to 230 robotic systems placed in the UK. So 4 per million population around. And we are doing about 300 cases per system. We can actually improve productivity to 400 per system. So we are just about there, but not yet. So that gives you an idea of what improvements have happened from 1995 onward in robotic surgery. So when you look at the ratio of procedures done vis-a-vis whether they are being done open or they are being done laparoscopically or they're being done robotically, so 93% last year, prostatectomy in UK were done robotically. They are still, I think, 3 to 5% being done open. I just need to know who is still doing open robotic prostatectomy. I don't know of anybody, but still the data suggests that. And you can look at partial nephrectomies as well. And you can see as urologists, we are doing the maximum number of a percentage of patients robotically. As you come down in rectal cancer, hysterectomy, so their figures are around 20%. So they are catching up. And it is because what we started 30 years ago of going everything endoscopically, reducing disease burden to the harm of the patient. We were early adopters of robotic surgery, much earlier than everybody else. Now everybody is following over there. So I think that's an important, and this is end of 2024. I think despite all of these things, when you look at the challenge that the NHS faces, so this is 2024. Last year, there were 21 million FCEs, finished consultant episodes. That's the patient came to see consultants. I think we don't talk about it. Urology is still very big. We are the 4th biggest surgical specialty in terms of volume FCEs. So highest is general surgery, is 2 million people, FCEs. Ophthalmology is number 2. Trauma and orthopedics is 3, and urology was 700,000 patients around. So we are the 4th biggest, and I think we should have an impact across in terms of policy as well, in my opinion. We don't have it. I think we can work on it. When you look at ENT, which is the next biggest, is almost half of what we do in urology. So that's the total FCs that we do, and I think we should actually use that volume that we have. So when you look at the patient on the waiting list, 7 million people waiting on the waiting list. General surgery, 1 million. Ophthalmology, 800,000, TO. And you can look at half of those. So the half of the work that we do in a year, patients are waiting. So if we started doing, so it will take us 6 months to cover that. Again, I think we should have an impact over here as well. So there is a challenge over here. So how do we actually overcome that? I think we are currently, I don't know, in Malthusian trap. So the needs are increasing very quickly, but we are unable to increase the production or the demand, manage the demand, and that is where we are. So how do we manage what we are trying to do? So how do we overcome that? In my opinion, is we can do that by using artificial intelligence or the products which are supported by artificial intelligence. I mean, I actually even asked ChatGPT and also other things. I'm going to give a talk. What should I do? And it gave me 3 different versions of what should I do over there. So everybody now is using in their chats some kind of information. I think we have focused on classical artificial intelligence. In my opinion, the next 30 years will be physical intelligence, i.e. intelligent machines, and also ambient intelligence in which, as we are talking around, everything can be transcribed and summaries can be made. So we don't have to do things, and things will be done around us. So there is going to be more pressure and more development in that area. So for the future, I mean, this is my last slide and I'll finish it. And for the future, I think we are already seeing large language models. They are being applied, ChatGPT and Gemini and other things. And they will have more impact in what we are going to do. I think federated data platforms, these are the platforms in which the data can move across and we can access data. They are already established or being established. Government has spent about £1 billion on developing FDPs across the NHS. And I think we need to use them. We need to develop projects on them.